Thank you for joining Vessel Health Talks number 10. Part of Hemostemix. My name is Kroom Lawrence, Chief Commercial Officer. We are super thrilled to have such a big group with us today. As always, we invite our entire community of physicians, patients, our friends in the regulatory community, and in the United States, Canada, around the world. We're very grateful for your time and participation. We have a lot of really great content for you today. Especially excited to have our CEO, Thomas Smink, is here. Today's focus is going to be on chronic limb-threatening ischemia and wound care. You all will recall last week we talked about heart failure. And before that, we've covered our AI strategy. We've talked a lot about our work around the world and here in the United States and in Florida and so forth. But today we're going to have a special session on wound care and CLI. There are some physicians and some patients that are interested, and so let's dig into that particular topic because it's important. And we have a lot of great data. So these are the three things we're going to discuss: the disease burden, our product candidate, ACP-01, and accessing care. Our mission is all around transforming CLTI and wound care. Our primary audiences are healthcare professionals seeking advanced treatment for no-option patients. Our purpose is to help our investors who are interested in revolutionary regenerative medicine opportunities. Our community leadership is on helping patients and families search for hope, and our economics, supporting our payers with highly cost-effective solutions to reduce the cost of care. And we have some really great data for you today that I'm excited to share with you. As always, our disclosures include, but are not limited to, ACP-01 is an investigational therapy. It is our product candidate that is under development. It is not approved by the FDA. Access to this investigational therapy may be available globally and in some U.S. states, including Florida, under very specific state guidelines. There are other states that we are keeping an eye on as they write their own potential legislations to provide access under specific criteria. Patients are required to have informed consent and be advised of the investigational nature of ACP-0. You may travel. Please consult with your physician. Treatments now are generally out of pocket and may not be covered by insurance. CLTI is the most severe form of peripheral arterial disease. So that's really the right starting point. Peripheral arterial disease is a circulatory condition where narrowed arteries reduce blood flow, in this case to the legs, due to plaque buildup, which is called atherosclerosis. 6.5 million Americans over 40, 200 million people worldwide with PAD, with risk factors around age, smoking, diabetes, high blood pressure. 40% of our PAD patients show up with no symptoms, and so there is a hidden danger. And we often have to talk about, it's crucial to get out in front of serious complications. There are certain warning signs like leg pain or cramping during walking, pain that stops with rest. And then in the most severe cases of PAD are the non-healing wounds, rest pain, gangrene, things of that nature, which it could lead to about 150,000 amputations annually in the United States, with all kinds of cardiovascular complications. So a call to action is early on for any patients on the line. If you experience any leg pain while walking or have risk factors like diabetes or smoking or wounds that won't heal, please talk to your healthcare provider about PAD and CLTI potentially. Early detection and treatment can prevent serious complications and improve your quality of life. Wound care and CLTI has had at least a century of profound innovations, beginning with earlier in the 1920s through the 80s around surgical bypass and angioplasty, into the 2000s with stents and drug-eluting balloons, through advanced dressings and hyperbaric oxygen, then into regenerative approaches like stem cells and growth factors, skin substitutes. And then obviously we talk about ACP-01 as it relates to our autologous stem cell therapies, where your own blood can be used now to abstract stem cells. They can be recultured to potentially improve blood flow and help regenerate tissue through healing. And we'll talk a little bit more about that. So what is our investigational therapy, ACP-01? The product overview is that ACP-01 is an investigational autologous stem cell therapy by Hemostemix with over 20 years of clinical development, 90+ patents derived from a patient's own blood to treat ischemic disease. We've talked a lot about the internal impact of peripheral arterial disease and ischemia, where it affects heart and limb and brain. And we'll look at that data in a minute with focus on limb. What makes our stem cells unique, the angiogenic cell precursors migrate to the injury sites. They promote new blood vessel growth, reduce inflammation, enhance tissue repair. And that's what makes that exciting and transformative from managing symptoms and all the way through amputations to really getting to the root cause of disease, which is why everybody's excited about the cell and gene therapy that it's emerging in the last 20 years. For us, we're looking at all forms of potential areas of ischemia, including CLTI, but angina and pain, ischemic and dilated cardiomyopathy, congestive heart failure, which we talked about last time. There are potential applications in vascular dementia we'll talk about. We've published on the opportunity on brain-computer interfaces, which is interesting. You can see that in the publication Cells. We had our chief medical officer, Dr. Henderson, talk about that a few weeks ago, and would like to have any conversations on that further if there are any questions or if anybody wants to reach out. It's a fascinating piece of study. We've had 498 patients across 7 trials, 318 subjects with preliminary safety and efficacy data on ulcer healing, wound salvage, and ejection fraction improvement in cardiomyopathy, which we've covered. Availability for ACP-01 under compassionate use and special access programs is beginning in December of this year, with production scaling with Cytoimmune based in our US Good Best Practices facility. The mechanism of action of ACP-01 is fascinating. It's always intriguing to me to look at the capability of reculturing of cells. And frankly, it boils down to a 2-step process where we abstract the stem cells with our technology through a simple blood draw. We're able to isolate the angiogenic cell precursors. We are able to then activate angiogenesis, which is new blood cell formation, helps with inflammation reduction, releasing growth factors and cytokines that activate the body's natural repair, and the targeted delivery where intracoronary or into the spinal fluid in the case of vascular dementia, or direct injection in the calf muscle in the case of limb salvage, where that precise administration to the damaged areas helps to optimize the therapeutic impact. So that's always fascinating to learn how the stem cells work. If we dive into chronic limb-threatening ischemia itself, CLTI represents the most severe manifestation of peripheral or artery disease characterized by rest pain, tissue loss, or gangrene due to critically impaired limb perfusion. There is a multidisciplinary care center of excellence around every patient, and it is profound and complicated and high functioning, but all the hard work from podiatry to vascular surgery to interventional cardiologists to great support services and wound care. There are many people who work very hard to take care of these patients. There's a lot of complexity, and we're going to talk about what the guidelines say about this care. But optimal CLTI management requires coordinating multidisciplinary care with patient-specific treatment selection based on lots of complexities and comorbidities and functional status. And the point of view from the guidelines and the literature, and our point of view, is that early support around improved vascularization, improved blood flow with targeted therapy helps to minimize amputation rates and improve the quality of life. And we're going to talk about why that's important. The guidelines are pretty clear around first-line therapy is to reduce cardiovascular risk, antithrombotic therapy like antiplatelet therapies, on to cardiovascular protection with statins and ACE inhibitors, addressing underlying atherosclerosis, controlling hypertension, and then any sort of symptom control around pain management and wound care protocols and aggressive diabetes management. These are all key parts of first-line therapy. First-line therapy also includes, as we just talked about, wound care and infection management, surgical debridement, targeted antibiosis, advanced therapies, including hyperbaric oxygen, which is interesting and has a very nice beneficial effect, obviously. On to endovascular therapies like ballooning, stent deployment. These are important. And then into finally to second line, surgical bypass and revascularization. We're going to look at some data here in a moment where autologous vein grafts, prosthetic conduits, these are important. And then finally on to no option. So if patients are not a candidate for any of these procedures, or if the efficacy is not happening, then there is a final bucket around palliative care, amputations, whether minor or major amputations, and then investigational therapies, including stem cells, which is where we come in. A risk factor modification is important for anyone on the line. Obviously, smoking cessation, glycemic control, supervised exercise are essential as well. Emerging therapies around regenerative care is where we are. So I'd like to now get into the medical perspective. I'm going to be covering some clinical data that we've covered almost every week that we meet. Just we continue to unpack this data and derive better understanding. And it starts with the epidemiology and burden of CLI, the disease incidence of 200 million plus worldwide, 12 million Americans, even as it relates then to the PAD incidence down to amputation incidence, 6-month amputation rates of 10 to 40%, 50% for diabetics. The mortality rates are really most concerning at 50% mortality at 5 years. And then here's a bullet: after major amputation, the 1-year mortality of 40% is concerning. We're going to cover costs in a moment, but essentially from peripheral arterial disease to chronic limb-threatening ischemia, then to amputation. And that's really where we come in. And so I think everybody in the call, or if you're new to the call, this is our range of 7 published studies. 3 of them I'm going to highlight today: Mutiranga, Szabo, and Henderson. These are 3 open label studies, and I'm going to cover each of them in turn. The aggregate safety profile that we highlight across all of our studies, and I think this is fairly unique to autologous stem cells that are derived from your own blood, is that this is an office procedure that can avoid anesthesia, no complications associated with bone marrow harvest. There's a sense of safety around autologous cells that have no risk of tainted blood, no parasites, no risk of neoplasia from pluripotential cells, and then no ethical concerns as with fetal tissue. That's been a thing over the last 10 to 20 years, as anybody knows, have been following the category. And then, no risk of transmissible spongiform encephalopathy, which is Jacob-Creutzfeldt's disease or mad cow's disease, and then low to no risk to medical providers. These are some of the bullets that Fraser Henderson covered. He's our chief medical officer, and please ask any questions about that. Mutiranga, from his study in 2009, CP01 cell therapy patient option, peripheral arterial disease, reported no procedural complications, 83% improved distal circulation, 80% complete healing of ulcers on his sample size of, let me go back, I want to confirm that, on open label randomized of 6 patients. So that's very early as a phase 1. Sang, subject randomized ACP01 versus placebo, direct injection into the calf muscle. The inclusion criteria is critical limb ischemia with systolic ankle pressure less than 70, not candidates for revascularization. Primary endpoints included time to major amputation. Secondary endpoints were wound size and pain. So the results of the study as a phase 2 clinical trial, ACP01 healed ulcers from CLI. You can see here, using the paired t-test from initial visit to visit 7 in each group, ACP01 showed significant decrease in ulcer size, a p-value of 0.005, sample N of 25 test group, N of 9 in the control group, and then we are noting a trend to fewer amputations and deaths with ACP01. The amputation and deaths at 12 months, 4.8% with ACP01 of amputations, 4.8% death. The placebo group, N of 8, 25% amputation, 25% death, which really is in alignment with US Medicare studies showing 15% amputation, 20% death. Dr. Henderson is then also, in the bottom left here, calling attention to a New England Journal of Medicine international randomized trial of 1,830 patients with CLTI, where at the median of 1.6 years, amputation above the ankle or major re-intervention for limb salvage occurred in 42.6% of the surgical group, and in 408 of 711 patients, 57% of the endovascular group. And we're going to come back to this New England Journal of Medicine study in a moment to look at their cost data. When you get into the economics and the cost effectiveness in that New England Journal of Medicine study, it's quite interesting. So this is the best CLI trial, the best endovascular versus best surgical therapy in patients with critical limb ischemia study published in New England Journal in November of 2022. That's worth looking at. It included a detailed cost effectiveness analysis for its 2 cohorts. So the initial procedure costs for surgical bypass were $25,000 to $30,000 per patient. The endovascular therapy, $15,000 to $20,000 cost per patient. The reintervention patterns For the endovascular group, 31% required major reinterventions, $15,000 per patient. In the surgical group, 23% needed reinterventions, 5 to 8,000. And so if the total cost analysis, the surgical approach was 35 to 40,000 cost per patient over 2.7 years, and the endovascular approach was 38 to 45,000 total cost per patient. The cost drivers were primarily due in the surgical group due to fewer interventions, which reduced the long-term costs for hospitalizations, procedures, and amputations. The endovascular therapy's higher reintervention rate, which were repeat angioplasty, stenting, or conversions, offset its lower initial cost. Amputations themselves cost 50 to 70,000. And as we then further the analysis, the lifetime costs for patients going through amputations that are below the knee or above the knee require ongoing medical care, hospitalizations, prosthetics, et cetera. One study, you'll see my references here below, Farber, Mustafa, and McKenzie, are showing the first year $100,000 to $125,000 that includes the procedure. Subsequent years are 70 to 80,000. It looks to be 250 to 390,000 over 5 years. Some of the highest estimates are $794,000, but that may include longer survival and other societal costs like job loss or inability to get back to work or to do things that you're able to do before the amputation. The service that we focus on and the value proposition for product candidate ACP-01 look at the system-wide benefits to help reduce amputations, reduce readmissions, hopefully aim for fewer complications, longer-term quality of life for patients, reduced out-of-pocket expenses, and obviously by getting to the root cause of the disease itself and foster healing to break the cost cycle. And that's a big part of our mission, is to understand the economics of where ACP-01 fits in as it's an initial investment, a break-even point, helping to reduce utilization, and then to sustain health and quality of life. So these are things that we will be conducting further studies and economic analysis going forward. Our clinical care workflow, which we've covered each week, begins with a referral from a physician where a patient who is suffering and diagnosed from CLTI and PAD is referred either to a clinician who is trained to qualify or administer ACP-01, whether that is globally or at new facilities that will be coming online in Bahamas, Dominican Republic, Canada, Europe, Asia, and potentially in Florida as that further develops and we further understand that opportunity to go to market. Our clinicians qualify the patients or rule them out if they are not qualified. And if they do progress and the review of their diagnostics align with ACP-01 therapy, patients are notified. Care and navigator support specialists help our patients understand scheduling, traveling, booking, and payment options. And then finally, as we've discussed, the first blood draw is taken 7 days later. Step 2 of care comes in, which is the readministration and the injection of ACP-01 cells into calf and foot to administer the cells themselves. And then we go into follow-up care and to post-care monitoring per our clinical study guidelines. So what we've been discussing in terms of our clinical trial development and in terms of our post-treatment follow-up is to align post-treatment care and capturing real-world data in alignment with how we're going to be structuring our clinical studies going forward, which we have several that we'll be discussing from an IRB perspective. Finally, in our second to last slide, which we've covered, there are 3 ways to that we're helping our patients to access care. One is through our treatment convertible debentures. That is a way to purchase and reserve your therapy. As we are all understanding, and as our audience is understanding, the manufacturing of stem cells and the reculture of them has to happen in a very specific sequence. We scheduled that, the manufacturing and reculturing of the cells, so that they arrive exactly when you are scheduled to receive your injections. That has to be orchestrated. So it's best and is necessary to have that scheduled in advance. So reserving your therapy is important. We are also in engagement with several banks to get low monthly payments. Right now, we're estimating that at $800 a month for payment for financing. And then our 501c3 foundation, which we think is essential for people of means who can help support others that cannot afford care to buy a treatment for yourself, but also to donate one. We're very grateful for your consideration there, so we can continue to help people have access to our investigational care. Finally, for physicians and patients, please reach out to me for clinical trial enrollment. We do have our registry up and live on hemostemix.com and on vesselhealth.com. And if you have any questions on compassionate use or payment options for medical affairs, please reach out to Fraser Henderson. He is a brilliant scientist and clinician, and it's always worth getting some time with him if that is of interest. And then for investors or for any questions at all, please reach out to Thomas Swank, our CEO, who has deep expertise in all of this. And we welcome all of your questions.
Great job, Krim. Just, if I could summarize, I would say that the key things that you've described here are, let's start with mortality. In the randomized phase 1 and the randomized phase 2 studies, we reported 0% mortality as compared to, in the treated group, as compared to 20% mortality in the placebo group in the phase 1 and 25% mortality in the placebo group in the randomized phase 2. And so there's obviously a very significant difference. And then I think the other point that you've made, which jumped off the page to me, was the cost of care over the term of the illness. If you compare the cost of an ACP treatment to the cost of care over the term of this disease, what we're saying is essentially a one treatment, will save the healthcare system. We in a 5-year increment, we believe 3 of 5 years of expenses. And the reason I use a 5-year increment is because in the randomized phase 2 study, the University of Toronto and University of British Columbia published that at the 4.5-year mark, they had 83% of subjects experience healing of ulcers, cessation of pain, and no amputation. And so we know from the randomized phase 2 data that this persists at least for 5 years. So that's a significant cost savings. We're going to obviously detail that in a economic study, but nonetheless, if you take it from the perspective of the patient, imagine being pain-free every day. Imagine what that's like over the course of 5 years as compared to the description of, going down the slippery slope of the standard of care that you've described. It is really quite a significant difference. So, the point of these webinars is not only to educate our shareholders and to speak to clinicians, regulators about this in what I would say is layman's terms, but also to reach out to those patients who are in pain, who are suffering, and bring this to their attention so they can have the conversation with their physician about obtaining this treatment as compared to a no-option patient who is facing limb amputation or hopefully someone catches this sooner in the in the disease cycle. But that's critical limb ischemia is just a very debilitating disease. We're seeing this in the day-to-day in the calls that I'm taking with respect to patients or the family member who's calling to say, look, when can we get my dad treated? Are we still on schedule for December? And my answer is yes, we're still on schedule for December. Well, fantastic, because we can't wait another day. This is just debilitating. So great job.
And thank you, Thomas, for your remarks just now. That was very helpful.
Yeah, my pleasure. I do to perhaps make another comment about the fact that the data you've presented today is based on phase 1, open label phase 1. 83% of patients experienced healing who otherwise would not have healed. The randomized phase 1, where all patients were followed for 2 years. So imagine, as compared to a 20% mortality rate in this patient population, that reaches 50% at the 5-year mark. The randomized phase 1 results were 0% mortality in the treated group and 70% of limbs saved from amputation, as compared to 2 deaths, 20% mortality in the normal care group, and 75% of limbs amputated. And then, of course, our randomized phase 2 data, where you quite rightly pointed out not only statistically significant wound healing by month 3, but lower mortality rate, 4.8%, as compared to 25% in the placebo group. Again, that's very significant in this disease area. But on top of that, Hemostemix has treated a total of 498 patients, and we have clinical data that is relevant, statistically significant, demonstrates safety, demonstrates efficacy in the treatment of not only peripheral arterial disease, critical limb ischemia, but also the heart, angina, buildup of plaque in the arteries, ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy. So this is where the heart thickens, the heart wall thickens, and the heart remodels itself. And we're seeing a reversal of that as measured by left ventricle ejection fraction improvement in the most recent publication of 53 subjects. We saw statistically significant improvement in left ventricle ejection fraction of up to 27% in the patients suffering from ischemic cardiomyopathy and up to 47% improvement in left ventricle ejection fraction percent in those patients suffering from the remodeling of the heart, the non-ischemic dilated cardiomyopathy. So yes, all to say, we're quite excited about the opportunity of working with the physicians and the regulators and with these patient populations, and are on track to do so starting in December.
Fantastic. Thank you, Thomas. We'll post this on YouTube. I hope you'll go back and take a look at it. If you have any questions, please reach out to Thomas or me, and we'll answer questions right away. Thank you for all of our familiar friends that come every week, and thank you to all the new people that have joined us today. We're very grateful for your time. We appreciate you being part of our community. Please come back every week for Vasel Talks, and we will keep you posted. Please reach out directly, and we are very service-minded, and we'll get back to you as fast as we can. Thanks again, and have a wonderful day, and we'll see you next week. Be well.